All
Do you
right.
want me to close this and then reopen it under the link?
All right. So let's close it and open it on that link. Yes.
All right. How's that? Okay, because I can't hear you over my headphones. I can't hear you over my headphones, but I can hear you on the phone. Yeah, let me hang up. And do you have your microphone on? Okay. I'm going to go ahead and hang up then.
Yeah. Steven, can you hear me?
Yeah, I can hear you now. Can you hear me?
Uh-huh. Yes, Steven.
Am I too loud?
A little bit loud, but that's all right.
How's that?
Yeah, that's much better.
Okay.
All right. So I'll just upload the slides here so you can also see that and you can control the slides. Do you see the slides?
Yes, I do.
So are you able to navigate between the slides on the same screen?
Yes, I am.
So you can go ahead and you can do the same if you would like to switch between the slides and like we discussed yesterday.
All right. And who's going to handle the poll?
So the polls can be handled by even Kaylin as well because there's a webinar jam and she's pretty much aware of this. So just in case there's some issue, I can do that.
Okay, because we got about 15 minutes before it starts. I just want to make sure she knows that.
Let me give her a call just a minute.
And then will she read the poll, or does she want me to read the poll and then?
Pretty much it would be she would be reading the poll and you would be responding to that.
Okay.
And she would also give you the percentage like we discussed.
Great.
All right, let me just give Kaylin a call. Just a minute, Steve.
All right.
Be right back.
Nope, you're calling me.
Yes, Stephen, can you hear me?
Yes. Can you hear me?
Yes, Stephen. I think there was some huge rattling sound there. It was really loud.
Oh, really?
uh Yeah, I think there's no other external sound. It's pretty much clear. So probably you could come a bit closer. I think that would be more better.
Okay. Okay. How's that?
Yeah, that's fine. That's fine, Steve.
Okay.
All right, so I'm just getting Kaylin set, and she's just about to join the session. All right,
All right.
she's just having some technical issues.
So she'll start it out.
That's right. She started out. Yeah.
All right. Very good.
All right, Steven. She should be up in the next 5 minutes, so we'll just wait for her. All right.
All right.
Steven, I think there's some kind of sound there, a slight interference sound, probably with the microphone, and there's some electrical sound. I think that's when you come really close to the computer.
All right.
Yeah, it's fine now. Yeah, it's gone now.
All right.
It's
I
fine.
can't. I can't see the screen, but I'm.
I think your microphone is really close to something, electronics or
Yeah, I
something.
have my phone off, but I do have a lot of electronics here. So
So maybe that. Or probably it's your speakers which is on, or something like that. External speakers.
no, they're not on. Just my
Oh,
headphones.
all right. All right.
Good afternoon. Can you hear me?
All right.
I
I
can
think
barely hear.
I think you can just come a little more closer, Kaylin. I think he can hear you a bit.
Okay, let me see if I can turn up the volume. Is that better?
A little more.
Kaylin, can you hear us? Kaylin, are you there? I can't hear you now, Kaylin. Were you able to hear her, Steve,
No,
before?
just slightly. She turned it up, and after that, I couldn't hear.
Let me check on that. Let me check on that.
All right. Zach, I don't know how I'm in here.
All right, Steven, since we are going a bit off time, so let's just go ahead and start the session. So I can give you an introduction and then you can go ahead with the session, all right?
Very good.
All right. Welcome, everyone. Thank you all for joining us for today's webinar on lean strategies in healthcare revenue management. Did you know revenue cycle inefficiencies accounted for 15% of 2.7 trillion spent on healthcare, which is about 400 billion? My name is Zach Noel, and I will be your host for today's session. A brief introduction about us. Invensis Inc. is a leading healthcare service provider in medical billing, medical coding, and revenue cycle management. Inventis' expertise in healthcare domain has helped its clientele in the US to provide high-quality medical care by efficiently managing patient engagement and communication. Inventis has achieved compliance with US Health Insurance Portability and Accountability Act and have been operating since 2000 with an office in Wilmington, Delaware, USA, and delivery centers in Bangalore and Rajahmundry, India. Inventis is a 2,000-plus member organization that has delivered unparalleled services across IT, finance and accounting, healthcare, back-office BPO, e-commerce, photo editing, and call center for businesses to streamline their processes and generate greater ROI. A leading market research company has rated Inventis as one of the most prominent global medical billing outsourcing vendors in the report. Inventus also hosts webinars on some very interesting topics across various verticals, so follow us on LinkedIn and other social media platforms to stay regularly connected and updated on our upcoming webinars. Today's webinar will be presented by Dr. Stephen M. Wagner. He is an executive director and faculty instructor of the Paul L. Foster School of Medicine at Texas Tech University Health Sciences Center at El Paso. A faculty instructor a faculty instructor at Independence University in Department of Health Sciences for Healthcare Administration, Health Information Management, and Public Health. a research fellow at University of Phoenix, and he has over 40 years of experience in revenue cycle management for hospitals, academic medical centers, and physician practices. He has also authored a book on health insurance and health outcomes. How does health insurance change patient health behavior? And many other journal and peer-reviewed publications. So just a little housekeeping before we get started. If you have any questions during the presentation, please type them in the Q&A panel, which is on the right side of the screen, and I will bring them up at the end of the presentation. Also, there will be poll questions during the session, so kindly participate to make the session much more interactive. Now, without further ado, I will hand it over to Dr. Wagner to take this webinar session forward. Over to you, Wagner.
Okay, well, hello everyone, and good morning, good evening, and good afternoon, since we have participants from all over the place. Glad to have you aboard today for this webinar, which is somewhat of a redo from one that was held on September 28th. So those of you who were there then can also hear the recording of this. And since it's a redo, it really has a lot to do with Lean Six Sigma and redoing it because we had technical issues, finding the root source of the problems, fixing those problems, and redoing it again so that we can conduct this webinar. So you'll see by the end of this session that you should be able to identify the Lean Six Sigma criteria that was used to reproduce the webinar, if nothing else. It comes full circle. But to go ahead and begin, in order to understand lean strategies, we have to have a brief history of Six Sigma. And many of you may have already heard of Six Sigma, Sigma being the Greek symbol for deviation from the mean. And when you include deviation from the mean, it means that when you produce something, the deviation needs to be very small in order to be relevant and viable in any kind of research. And so Six Sigma is how close the deviation is to the mean, so that you have a near perfect end product when you are working with quality production. And so just as a brief history, we see that quality management dates back to the 18th century, involving accuracy of parts to produce quality products by hand. And in the late 19th and early 20th century, Henry Ford included a lot of what is included in Six Sigma because he was one of the first to employ the assembly line procedure. And in the assembly line workflow, parts are available in each section of the assembly line. And those parts have to fit exactly right or near exactly right, so that the quality product at the end will produce a car that can be driven and that will be held together and will work just fine. And the same process is in place today. Of course, there's a lot of robotics in car manufacturing today, but the Six Sigma process is still in place in most, if not all, of car manufacturing. And so quality control and management back in the 19th and early 20th century took a higher priority in production, especially due to the assembly line process. And continuing with the brief history, the Japanese took on Six Sigma, and not just Six Sigma, but the quality control processes, so that all the parts fit just right, so that you have a longer lasting and enduring product for whatever it is that you're producing in consumer goods. And the more efficient one became in Japan at the time, the lower the cost of the production of these goods, because in the production of the parts too, to make them near perfect meant that you didn't need as much labor. You can develop and innovate more machinery to make the machinery. And you could produce more goods and sell them at the same price. So you had higher productivity and higher profitability. And so by the mid 1960s, productivity and quality improvement methods led to what was known as TQM. And some of you may be as old as I am and remember TQM as total quality management, and which moved from quality improvement from production line of consumer goods to service lines in service. And one of the biggest services is hospitality, but also in healthcare and anything involving the process of service lines in healthcare. So TQM emerged as an integration of working and reflecting that focused on meeting customer expectations. And when we talk about revenue cycle management, what are those consumer expectations? Most people expect that if they're going to provide us with their insurance, that insurance is billed, that they're charged for the correct copay, coinsurance. But meeting those expectations is very important at TQM, inclusive of all members in the institution, which means that TQM was something that hospitals took a hold of and presented to their entire staff. And every department in the hospital would have assigned to them a total quality improvement process, which included continuous quality improvement, which meant that improvement never dies, that nothing is ever, I shouldn't say good enough. Things can be good enough, but it can always be improved upon to make it better and increase the patient centricity and satisfaction of that service. And understanding and quantifying the costs for quality and the costs for failures of quality. And so in determining all this since the mid 1960s, we found in the healthcare industry that the costs of failure can be quite costly and cost more than the costs for making it a quality product or a quality service in the first place. And then TQM also was focusing on composing the process rather than the production inspection. So if you relate it to producing cars, you don't want an inspection of the car after it's been through the line and then find out that it's faulty and have to put it back in the line. If you relate this to revenue cycle management, it's like viewing the claim after it's been rejected by the insurance company. You've just produced a car or a claim that does not work. And so if you're going to do that, you need to go back to the process and the workflow process and putting these things together to make sure all the parts that go into this quality product are there before the product is released, whether that's a car or whether that's a claim. And then integrating policy and procedure in your organization to support improvement methods and rewards for the development and flexibility for change. And we all know that as human beings, we have a very hard time accepting change. Change can be difficult. Change can create anxiety. But it also creates a lot of excitement and a lot of energy to see that what has been identified as a problem, researched, fixed in the assembly process, and watching it work is a very telling moment for staff and for physicians and for revenue cycle management in general, and instilling innovation and continuously envisioning processes for improvement. And many of you may remember that not too long ago, paper claims were the standard for the day. Sending paper claims by mail, a lot of times we would attach a card to register that mail, so somebody would have to sign for it so we know they got it, and then we'd follow up by telephone, one claim at a time, and it would take a very long time, and it wasn't a very good process. And so including technology and innovation into our processes, now most, if not almost all of our claims, our original claims, are sent electronically. They're processed electronically at the insurance companies, and we're notified about the status of those claims electronically. And when we call, many times we don't call by telephone. Many times we call by portal, and we can batch check the status of claims in revenue cycle management. So innovation and instilling innovation is part of the Lean Six Sigma process. So what does Lean Six Sigma mean? The TQM process waned in the late 1990s, and that took quite a while. It lasted for about 20 years, but it wasn't so integrated into the process that it was a formalized process where you would train people on noticing quality problems and finding solutions for them and formalizing that process. And so it began to be ignored or passed over, and there were so many regulations and so many things that needed to be done that TQM waned. But at the same time, the government put together, through the Department of Commerce, the Malcolm Baldrige Quality Assurance Award, introduced in 1987. And this was part of the Quality Improvement Act by Congress, and it was personally awarded by the US president. And Motorola was the first to win this award, based on a TQM type project that expanded production quality by fully integrating the process into its manufacturing of electronic processes, but also not just integrating the process, but making it a formal process that management would recognize, that they would have quality improvement tiger teams, as they called them, to come in and find the problems, even to the extent that they would ask the staff or the line personnel, where are you finding the obstacles in producing quality products, and let's research them, and let's research the research that we're doing. And so this became very interesting, and Motorola created the DMAIC process, called where you would define the problem, measure the extent of the problem, analyze it to find out what was the root cause of these problems that would lead towards improving the process. And then after the process was improved and reanalyzed, it was then controlled to ensure that this problem wouldn't happen again, and then begin again to start on the next problem, because problems tend to be problems and issues in quality control tend to network themselves. So you have one problem. Once you fix that, you've opened the Pandora's box of the problems that have occurred because of that, or as a result of that down the road. And sometimes your fix causes additional problems down the road that also need to be fixed. But the idea is to create quality, efficiency, and effectiveness in this error control, quality improvement type of process, which became known as Six Sigma because of like I mentioned earlier, when you measure how close this quality control has been improved, you measure how far from the mean or the desired metric that you say quality is, how far from that is this production and this quality improvement. So Motorola institutionalized this process and created Six Sigma employees whose only job was to not only learn about the DMAIC process, but to teach it to others and to use it to train users on controlling their own process or owning that process for quality and reporting additional problems that may occur, so that the green belts and the black belts, they had these levels of expertise in Six Sigma. Only on DMAIC, and handed off the project to process owners for implementation. And so Six Sigma began with Motorola and the Malcolm Baldrige Quality Improvement Award, and it spread. And this was widely written about. And even today, when you go to a website, if you've looked up Six Sigma before, you'll find advertisements for Six Sigma training online, or in schools nearby, or in companies that will provide their own training for Six Sigma. So what is Lean Six Sigma? Well, first, let me tell you that Six Sigma, here's your Six Sigma standard deviation right here. If the results did not meet the expected outcomes, then the black belt and green belt teams were sent in again to rework the process and do it again. Now, yes, this took time. Yes, this took fortitude, and it took patience on the part of management. But in the end, Motorola claims that having done this and taken this time and making this investment, that they claim in their financial statements over $16 billion, $16 billion in savings from Six Sigma projects since 1987. Now, that was 30 years ago, which makes it about $500 million a year if you were to average it out. I would think that if we saw a graph, we would see most of the savings at the beginning, while these savings kind of wane towards the end. But as a result, $16 billion over that period of time means much more in inflated dollars, less so since 2008. So right now we have a Six Sigma poll question.
Yes, Steve. So I'm just opening the polls right now. So yes, Steve. Do you see the polls on the right side?
I do not.
How about now?
No, nothing's changed.
All right.
On the right side.
So I do see some changes on the polls, so I can tell you the percentage.
Okay, so you can tell it to me. So how many participants include a formal Six Sigma training and process in their institution or their practice, or in their quality improvement? Do you have a quality improvement department? And so A is yes, B is no, and C is unsure.
All right, so we have like 43% on yes, 29% on no, and 29% on unsure.
All right, so I'm hoping that the 29% that is no, or and also unsure, which is about 58% of you, will consider Six Sigma in a quality improvement department, or at least the Lean portion of Six Sigma. So we'll get to Lean, which is right here. So Lean is not the entire Six Sigma program, and that's why it's a Lean Six Sigma. It's a skinny Six Sigma, if you will. And in the Lean management process, it is, instead of define, measure, analyze, improve, and control, we have plan, do, check, and act, or PDCA. And that is basically a skinny Six Sigma, or as we like to call it, a lean strategy of the same process of Six Sigma. And so this is an offshoot, and lean management does not call for statistical measures of near perfect performance like Six Sigma or do-over, because finding the Six Sigma or finding the standard deviation from the mean in service lines is very difficult and somewhat amorphous. So lean management calls for quality and cost containment to agreed upon metrics and expectations. So that's the measure. And so if we put this in plain language, in plain English, cost containment, quality, and accessibility are the three precepts of the Affordable Care Act of 2010. And it applies to revenue cycle management in ways that it applies more so in revenue cycle management than anything, because what is the main component of the Patient Protection and Affordable Care Act is claims and insurance. And so in terms of regulation and data gathering and workflow and process improvement and holding down administrative costs that in healthcare take up 30 to 60% of the costs of healthcare. And so lean management is a strategy in revenue cycle management that is a must in order to obtain quality, cost containment, and certainly accessibility for patients. So lean management does not require the specific education on productivity and quality management to ensure that you have a specific standard deviation, which I mentioned before. And lean management does provide for accountability for ownership and planning, testing, performance, and measurement to objective metrics and actions to readjust or retry another method, which means that you put your minds together that work in your institution, that have input into each process that you define as an issue that is obstructing your quality production. And in revenue cycle management, that would be quality production and payment of claims through adjudication. So lean management includes all ideas for solutions to reach agreed metrics, which is like workflow smoothing. Workflow smoothing is taking, I saw in one institution in which I was consulting with, when you mapped out the workflow in the revenue cycle from registration all the way through adjudication of claims in the business office, I saw that there were many, many workarounds and handbacks, and you have to fix this because you're the one that put it in the first place, and how are you going to learn if we don't send it back to you? They would do it by fax. Sometimes the faxes were picked up. Sometimes they were filed in the medical record. I mean, it was a mess. And so there were offshoots and workarounds everywhere in the workflow process. So workflow smoothing is using your practice management system to work out these processes and assigned trained personnel, not necessarily increasing your labor force or decreasing your labor force, but using your labor force in a more productive way where you smooth out that workflow so that when a problem pops up or an exception pops up, that it can be taken care of before the claim leaves the door or before the car leaves the factory. So paperless workflow with prescribed instruction and desktop schedules and daily management dashboard reporting is how management will keep its eye on its production line in revenue cycle management. So training teams or super users, whether they're dedicated teams that are separated from the rest of the group, which is a Six Sigma-like approach, where you have a dedicated team of training and watching for the workarounds is essential in lean management to capture those that found a workaround and are not using the smoothest workflow process that the institution agrees upon. And you can find these because most of the time workarounds will keep some metrics from being met. And when a metric is not met and it's continuously not met is a signal. Outsourcing, coding, billing, follow-up, and collection to contain cost and link to outcomes is another Lean Six Sigma strategy that if you find that, well, I'm going to have to hire 25 people to be able to implement the Lean Six Sigma approach, maybe it's time to examine the outsourced companies that already have the Lean Six Sigma approach in their processes to notify you as the owner of these claims to see where the problems may lie and eventually be able to take it back once the outsourcing company has resolved these problems. And then you copy this process into your own organization. Now, what got to me, and in these next 3 slides, I have 3 different revenue cycle graphs or graphics that baffled me, and I'll cover them real quick. And why did they baffle me is because when this is revenue cycle demonstrative, and I've taken them from HFMA and MGMA and journals and took pictures of these revenue cycle phases and processes, where you start with registration or you start with scheduling and then registration. You have charge capture, coding and documentation review, etc., down to claims processing. You also have managed care contracting in there. Let's not forget about that because that's our case study today. And then as part of the process, they put in denial management. Now, denial management means that you're managing errors. So you expect, when you draw a graphic like this, you're expecting errors. If you're expecting errors, lean strategies will take you out of the expectation of errors and more in the expectation of payment posting and adjudication of all claims. So if we look at the next one, here's another one where they've added in not only denial management, but the appeal procedure. These both are error processing functions that they're accepting as part of the process, not as an exception to the process. And if you look at the next one, even though it is quite a bit smaller, you see that denial management is right here in processing these claims through these concentric circles that work around the patient-centric revenue cycle. This is a great graph, except for the addition of this denials management right here, accepting it as an integral part of the process. It should not be. It is an exception. So what does revenue cycle even produce? Well, it produces a financial record, the start of a medical record, because 80% of the physicians in this country and about 65% of the hospitals in this country use an electronic health record, or for hospitals, sometimes they don't use the entire electronic health record, but they use a lot of that health record. Revenue cycle produces data for claims processing, data for statements to patients if not collected up front, payment receipts, EOB records, payment posting. This revenue cycle process is a big process, a big part of what equals to dollars collected, which equals claims sent and paid quickly. So claims sent and paid quickly is the key to revenue cycle management, because we don't produce cars, we produce claims. But if we produce a claim with a door missing, or with an address missing, or with a birthday missing, and we send it out anyway. Yes, we meet the metric of sending out our claims within a certain period of time, but it's only going to be sent back. And we know it's going to be sent back because the insurance company is not going to correct it. They're going to send it back for you to correct, to make sure that you're sending in the right patient for the claim that represents the treatment. So a lean strategy in revenue cycle removes denial management from the process. So if you use lean strategies, the plan, do, check, and act outside of the routine production of claims, and find ways to prevent the denials and rejections in the first place, then you can take denial management out of the cycle as part of it and use it not as a rule, but as an exception to the rule. And so here is a case study that right after we do the revenue cycle poll question on how this was actually done in an academic medical center.
Hi, Stephen, can you hear me?
Yes.
I can't believe it. I actually made it in. This is Kaylin. So thank you for
Great to have you back.
Going so far. Thank you. Perfect timing for this poll question. So how many participants include a working section of staff dedicated to claims, denial, rejection, and appeals management in the business office? So if you could please answer that poll, either A, yes, B, no, or C, unsure. All right, we have some already starting to answer. Feel free to keep answering. So far, everybody has said yes.
Okay, so if we look at the previous examples of the graphics, we can see that most of us, that those graphics were correct in that we use specific employees and staff just to correct claims that are sent back for denial and rejection. I don't know what percentage, if it's all of them, I wouldn't be surprised, because everywhere I've been, that's the way it was. But including a lean strategy, again, will allow you to use those same employees who have much talent in correcting claims to make the claim correct in the first place prior to its being sent out to the insurance company. Now, in revenue cycle management, we saw managed care contracting, and here is a case study. And this is a true case study where I consulted with lean strategy utilized by a multi-specialty academic group practice with over 200 physicians and multi-specialties, everything from pathology. The only thing they didn't have was zoology, I think. But this company, or this practice, was contracting with different managed care organizations, and we noticed that the contracts they were signing had in their commercial contracts fee schedules that were approved for about 125% of Medicare. And in an academic medical center that accepts a lot of indigent care, because their teaching facility was the county hospital, that had a lot of Medicaid, not so much in Medicare, but a lot of Medicaid and a lot of indigent care. 125% of Medicare reimbursement on a commercial claim wasn't so bad. I know many of you out there probably have higher reimbursement rates. Some of you may have lower reimbursement rates, but 125% was something that the practice plan wanted to take a look at and say, is this the right percentage? We just accept it, but is it the right percentage? So the obstacles to income identified upon examination of every fee on the fee schedule showed an analysis of providers indicated all CPT and the Medicare and Medicaid rates per provider per specialty in primary care. So you had three columns. You have the contracted rate and what Medicare pays and what Medicaid pays. And from there, you can measure above and below what is paid above and what is paid below, because the 125% was a blended rate of all the CPT codes that the insurance company would pay for. When then the practice plan compared average reimbursement per total RVU over the last 3 years by all non-government or commercial payers. They calculated the total practice costs from the general ledger for departments net of education, because they were an academic medical center, they had a medical school, and funding and grants per total RVU. So they were just looking at their practice plan reimbursements for treating patients and the costs associated with that, just in general by the GL, took all their CPT codes, all their total RVUs, which included practice costs, malpractice costs, and the work RVU, and came up with an average cost per RVU. And what they found was that the estimated average margin between their cost and their reimbursement per RVU was about 200% of cost. So they were making twice as much as it cost them to do services on a blended rate, and 175% for primary care. Now, that means that the academic medical center, if you just take a quick and dirty analysis of that, that the academic medical center was keeping its costs under control, because they couldn't have this kind of margin over costs at these rates if that's what was happening in managed care contracts. So what happens next in the plan? So from the analysis, providers set budgeted margin metrics at these levels over costs of 190% over costs and reimbursement at 140% of Medicare reimbursement. Government payers not included. So, because, government payers are only going to pay either Medicare or Medicaid. So the commercial insurances, they were looking at their costs over the reimbursement, and then they were flexible with the payer mix, since the AMC teaching hospital was county, like I mentioned before. And the provider market, when you took a market study, indicated that the majority or some exclusivity of specialists at the academic medical center, but not for PCPs. So PCPs were plenty in the community, whereas the specialists, they had either a lock or the majority of the specialists in the city. So the lean plan, complete on contract negotiation with room for exception on volumes and exclusivity, providing overall market share of services at 20% to 25% for the academic medical center, and sometimes 90% of some specialties in the market. So now it's time to do something about it. So after planning this, they compared and contrasted most common or all specialty code reimbursement metric against the proposed contract fee schedule to see whether it met that metric of 190% for specialty code, and for primary care, 175%. They compared and contrasted the least common or non-used procedure against the proposed contract fee schedule. And what they found was that the insurance company, to get the blended rate of 125%, was paying very little on the most commonly used CPT codes, less than 100% of Medicare, on the most commonly used procedures in the academic medical center. And they were paying this enormously high rate on procedures that was not used by the academic medical center. And so where did they get these statistics to manipulate the fee schedule this way? And they got this from previous claims that were sent into this insurance company by this AMC, or perhaps upon their population of networks. This was very interesting and enlightening, using the lean strategy. And so the academic medical center created counter fee schedule to the managed care organization, which came up with the same blended rate of 125%, but flipping it to where the most commonly used CPTs were brought in over the 125%, and the ones that were not used or the least commonly used were brought in under the Medicare rates, but still came back at a blended rate of 125%. And so the anticipated rejection of some reimbursement requested for used procedures and counter with a bonus plan. So if they felt that they were using their metrics, they came up with this particular price, anticipating that this may be rejected. They were planning on using a bonus plan for quality measures and collaborative reconciliation between the two parties. So that is taking your plan and actually doing a counter proposal that incorporates incorporates anticipated rejection of particular codes, and without telling them or proposing that perhaps we can do this as well to help keep your costs down. Because in a good negotiation, you want to make the managed care organization happy, and you need to make the practice plan happy in order for both of them to have a good, solid reimbursement contract and revenue cycle. So to do this, the continuation of this was they checked the contract for any other requirements, such as waiting times for specialist appointments. When you're one of the few specialists in town, or you have 90% of the specialists, there's a great demand for these specialists. So scheduling is very, very important. And so this would take more lean management on the departmental level regarding specialist appointments, and how long does it really take? And is there any waste in those appointments? Patient satisfaction, ensuring that the patient was satisfied with the treatment, and using like a patient portal to provide reading for the patient to remove this informational asymmetry or the lack of understanding of the patient and the best understanding of the physician, and bring it more in symmetry together. That is also a lean strategy to create patient satisfaction, that not only did they help me treat my disease, but they taught me about my disease and what my risks are, and give the patient some say-so in this, which is what the ACA and the government is looking towards, to help the patient think about types of treatment that they want and that are the most cost-effective. And enrollment requirements. Enrolling physicians into managed care organizations is something that is in those contracts, and if they're not, they should be, to cut down the amount of time if the hospital's not already delegated to do that for the practice. So if the practice holds exclusive specialist presence in the community, consider lower rates in exchange for exclusivity and quality bonuses. So if you have exclusive specialists, you can talk to the MCO about sending all your patients to the practice for these specialties if you know that you're the only horse in town. But give them a reasonable rate, so you're not running off with the armored service that takes the money to the bank. And then the counter offer with proposed new rates, reasonable expectations for appointments, and accessibility, and then you reapproach them. And so you check. So in lean strategy, you check by finding out what the response is from the MCO, and you give them a week or two, not 6 months, to get back with you, just like you will take a short period of time to get back with them. So it turns out the managed care organization accepted the counter offer proposed fee schedule from the practice. They did decline a quality bonus program, and that was likely because they saw how much they would be paying for some of those specialist treatments, even though overall it came out to a blended rate of 125%, and the actual rate from those procedures being used kind of averaged out to about 140% of Medicare, 144% of Medicare, not 125%. And the MCO did not grant exclusivity for specialists or PCPs, but the practice found many referrals from outside PCPs for specialists in the network at the academic medical center because they were the majority, the vast majority, or exclusive specialists in town. So they got the referrals anyway. And then it was time to act. And in acting is like controlling in the Six Sigma process, where after implementation, 1 year later, they performed an analysis, and they found that comparing and contrasting, they met their and actually exceeded their budgeted metrics for costs over costs under reimbursements. And so it was more than 190% over costs, and it was more than 175% for PCPs. And in the end, they made $400,000 in 1 year in reimbursement for services performed over what they would have received had they accepted the first offer. And so this translates from this lean strategy into dollars and cents without our even talking about claims management yet in revenue cycle. But that was still part of the managed care process. So Kaylin, we have another poll question here.
We do, and I've gone ahead and opened the poll, so feel free to respond when you're ready. This one asks, how many participants, including a working section of staff dedicated to managed care contracting, analysis of proposed contracts, and counteroffer with lean strategy? Your options are A, yes, B, no, or C, unsure. Just making sure, Stephen, you can still hear me, correct?
I can still hear you.
Oh, good.
I'm hoping to hear an answer pretty soon because...
There are responses already coming in, so it's going a little back and forth. Right now, we're at 60% no and 40% unsure. Let's just see if a few more answers come in. It looks like there's some still responding. Nobody with yes yet, though.
Okay, so it's getting higher in the no category. And so if you had a dedicated staff working on managed care contracting, doing the type of analysis of using this lean strategy of analysis of your managed care contracts, this particular AMC is now doing this on every one of their contracts and looking to see which ones and when they can start their renegotiation process with their MCO. Now, there's always contingent factors like your geographic location, your population of patients that are covered under that MCO, and so forth. But this is one of the more successful lean strategies that worked with the managed care contracting portion of revenue cycle. And now we can go over real quickly here about claims edits, rejections, denials, and why. So we can move that out of the revenue cycle and put it in to claims processing. So if you evaluate all claims edits, rejections, and denials on 3 separate lists, what are the claims edits? What are the claim rejections? And those claim rejections are when you send them in to the insurance company, they're rejected because something is missing. And then denials because the service was not covered, the patient was not covered even though it was verified at the time of service. Those are used in lean strategy to fix this. So what claim edits are pronounced prior to billing but go uncorrected and pass through to accounts receivable? Because our billers, whether they're physicians or hospitals, are given metrics that they have to get all the bills out within a certain number of days, and they'll skip some of the information that's needed just to get the claim out the door because they're not responsible after that. So that would be a problem. Addresses that are missing or bad, missing certificate or insurance numbers, or they're put in wrong, birth dates that do not match to the insurance response, and if in your practice management system you have an insurance response system where you can send out for a response on verification directly from their system, I would advise taking advantage of that and using that, integrating it into your practice management system to keep your people focused on the patient rather than on simply verifying their insurance. And if you get an electronic response, you can pretty much count on that if you get it sent and responded to from the right insurance carrier. And the possible duplicate accounts in billing. And we find that happens a lot of time in the follow-up process because I have found in my consulting endeavors that in follow-up, instead of making a call or a batch claim status check over a portal, I find that some follow-up personnel will send in another claim. And if they get a response that says we don't have the claim yet, they just automatically send in another claim instead of checking to see whether that claim was not edited up here or somehow we have to check and see in the account and take the time and effort so we don't have a rejection sent to us on a duplicate account. So in the planning process, the notice of rejections received prior to denial and appeals made or not on rejections, time spent investigating. That is the cost of failure, is the time spent investigating, the labor resources used in investigating rejections that could have been prevented up front. Corrections made online with the portal. These, again, are corrections that could have been, if you examine all those that have been done, and the documentation required demanding paper transmission of data with return receipt requested is another cost of failure. And so the do in the plan do is root cause evaluation. So all of that above documentation and edits, rejections, and denials need to be looked at from defective front-end verification and pre-admission information gathering. And a lot of times, I say a lot of times, a lot is not a number. Many times, and I can't say it's the majority of times, and I can't say it's a few times, but we find that we're under-resourced in labor at the front desk, which is the most important part, where you have face-to-face centricity with the patient, a face-to-face relationship with the patient, and where everything can be taken care of, any doubts can be taken care of at that time. And so this is during the scheduling and registration process at the front desk, whether it's a hospital or whether it is in a practice plan. Staff evaluation and user inclusion in the process at the front desk, coding, billing, follow-up, and collection. In other words, bring them all in and say, this is what we found. This is the data we found. These are the things that we can correct before that claim goes out. And look at your practice management system to see whether you have a claims editing process that alerts the coder, the biller, the collection person, or the front desk prior to the time that claim is released to the insurance company, to notify them that this is unacceptable to the MCO, or this diagnosis does not match the CPT. All those things are available in practice management systems today. And compare the root cause evaluation of users to outsource evaluation. And again, you have to look at if you're under-resourcing at the front desk, if you're under-resourcing on the back end for follow-up and for things like that, many times, and this has always been, it was a dirty word for me many years ago because of the requirements that we have our own business office and that, we knew we could do it best. But today we have outsourcing that is very, very efficient and very, very cost effective, that can take over some of these processes without losing control of your practice or without losing control of your hospital business. And even large hospital chains centralize their business offices so that they're doing work for several hospitals in many different geographic areas is a type of outsourcing anyway. Although they may be owned by their own company, they're still outsourcing. And why? Because of the cost effectiveness of outsourcing, which is an option in the lean strategy. So solutions to review and doing in the lean strategy for claims is central registration or central pre-admission with standards. In other words, we need to review and not just cursively or do a cursory review of 10 charts out of 100 that we've done, but do something more on the Six Sigma side, which is review everyone, or find a way to make sure that it passes inspection before it's entered. Verification of information prior to arrival, and this is where your electronic response from your insurance company comes into play. And notification to patient of any discrepancies. And patients are more reachable today than they ever have been with cell phones. Now, of course, using text messages is something that you need to get their permission to do, because many times it costs money for every text message they receive. A lot of their calls cost money. But if they have an email address, if you can get their permission to send them emails, this is a good way to fix your discrepancies before the patient even comes in. Patient portals are extremely valuable in this process. And not only that, but in a way of getting paid through a patient portal rather than sending a payment through the mail. And I can tell you personally, anecdotally, I've sent payments through the mail, a check, and I hate putting credit card numbers on statements if I'm paying a medical bill. Because you have to put everything down there from your security code and everything else. But having a patient portal or an online way to connect and pay through PayPal or one of the other more secure forms of payment is an excellent way to increase your self-pay reimbursement. Calculation of copay and coinsurance and notification to the patient prior to arrival, and collection of that and reasons why it may not is something that we would need to listen to our front desk personnel, not just say, why didn't you do it? It's what is happening that makes it difficult to collect the copay from the patient? What are you hearing from the patient? How can we make the patients happier to pay that copay? And a lot of that is how the patient is approached and how the patient is treated when they're receiving their service too. And again, patient portal is an excellent lean strategy to using your labor more effectively. Confirmation of authorization and referral from insurance companies prior to arrival. That all has to be done. So again, the authorization and referral systems are many times incorporated into the practice management systems. And so if you don't know about that already, check your practice management system. And if your practice management system does not have it, again, think of outsourcing so you can rid yourself of the practice management system costs, bring it over to outsourcing, but always have a backup for yourself too, so that outsourcing may be something temporary for you. Or it could be something permanent depending on how it works out for you. But you have to set the metrics to be able to do that. And then in finding the root cause evaluations, I always say set the standard. So the standards are available in many cases from the Medical Group Management Association and the Healthcare Financial Management Association, from the Faculty Practice Solution Centers for the academic medical centers, where you can look at what the mean is, what is the expectation of all the other practices, and go a step beyond that and make your standard more stringent. Because the mean or the median, or at least the mean, is not always the best approach. Maybe you should think about, along with your users, can we beat the standard? And if we beat the standard, what's in it for everyone? What's in it for the patient? What's in it for the provider? What's in it for the staff? And ensure transaction notifications to coders and billers that arrival has a missing charge. Resolution of standards and reporting prior to claims outbound. Filing deadline notifications to staff and management. Reports daily on copay collections. And again, review with your staff what may be the reasons why copays are having a difficult time being collected, and then institute procedures that, using the lean strategies, that would be most acceptable to the patient and most encouraging to pay their copay and keep you from having to bill for that copay and send a statement and wait for that payment to come back, et cetera, et cetera. Missing fields notification prior to claims release. This would be in your practice management system on a claims editing prior or transaction editing process. Determination of process ownership and accountability. Who's going to be held accountable? To not enforce the standards, but try to meet those standards. Make it a contest. Make it something that is encouraging and blame-free as we move towards this lean strategy as a blame-free environment. Because what we're interested in is, we are interested in whether our staff is performing their job correctly. But a lot of times what I found is there a lack of training, a lack of policy and procedure, which goes back to our training staffs and our super users that are there to help those who are falling behind. And consistent low standard performance of individuals have mandatory retraining and second attempts prior to exit counseling. Nice way of putting that. But sometimes this kind of work is not meant for some people. And, convincing them that maybe another career is in the offing is unfortunate, but it does occur. But lean strategy can help you avoid those with the retraining. And then, of course, resolution measurement. Measure each issue at start from deviation of new standard set, not from the mean, but from the new standard set. Graph and measure each process from beginning for set period, which I would use no less than 6 months. I would use more like a period of a year, and each root cause resolution. So if your standard is not being met, look at it again for the root cause resolution, and then consider other lean strategies in case this seems unresolvable and it's the cost of failure, it exceeds the cost for improvement. And then set your standard at the back end for edits, rejections, and denials based on front end root cause resolution. And see and account for those hundreds of thousands of dollars that you're letting slip through the cracks or slip through the table by not using these lean strategies. And so you can determine whether the standards were met, exceeded, or did not meet the standard. And so you can act once you've integrated this process over and over and over again. It's cyclical, just like revenue cycle. Analysis results in met, exceed, or did not meet standard. And so if they were met Ensure the integration through ownership, responsibility, team practice, and new improvements, rewards, and accountability. So there's a carrot and there's a stick. But the accountability doesn't have to be a stick. The accountability can be retraining. The accountability can be second chances. The accountability can be certain warnings that are very polite and diplomatic and say, we understand that you're running into this problem, or this group is running into the problem. If the group is running into the problem, then we need to go back and either reset the standard or do the process smoothing. And then exceeding the standards, reset to reasonable expectation. Ensure the integration through ownership, responsibility, team practice, and new improvements, rewards, and accountability. But reset the reasonable expectation. So if you exceeded the standards, you've just raised the bar. Now, that doesn't mean that you raised the bar to what you met, which exceeded the standard, but you raise the bar just so much that in case of anticipated events such as we didn't have any flus this season because everybody got a flu shot, you may not get the visits you wanted, and then that's not the fault of anybody except good public health. So we want to be able to exceed the standards, but we want to be able to exceed them reasonably. And then finally, if you did not meet the standard, then you need to, through the lean strategy, examine documented issue obstacles, labor, training, absenteeism, time management, skill sets, and reset standards if unreasonable, and begin process analysis from the start. And so that is like Six Sigma starting again, but it's well worth it considering the hundreds of thousands of dollars just from that one contract at the, or that one case study of the contract at the academic medical center. So here's the one thing that you should be walking away with from this webinar, and that is that the lean strategy insists that errors are managed only by exception, not the rule. Take it out of your revenue cycle parts. It shouldn't be there. The people that are dedicated to denial management and rejection management should be in the process of correcting those problems before the claim even goes out. And lean strategy means error-free processing. And let me add, blame-free processing, so that we take the blame out, we remove the fear, and we motivate people to really accept the lean process, and that things do have continuous quality improvement. There is no saturation point for this because technology and innovation is always out there, especially these days. And here's other areas ripe for lean strategies: lag days from date of service to claim billing date, lag days from date of payment to date of posting, lag days from date of billing to date of payment, undercoding, overcoding, follow-up from expected reimbursement date. These should also be available in your practice management system. Lag days from expected reimbursement date, claim rejections prior to transmission, aging of AR, beyond metrics of like institutions. And this is one thing, aging of AR in like institutions are a pretty good standard from what I saw. And that most institutions get this, even the best performers to the worst performers, you could really see the difference. And correlation of metrics to gross charge collection percentage to gross AR days. So if you have a gross collection percentage of 20% and your AR days are sitting at 25, there's something wrong. So either you're way overpriced, where your contractual adjustments are just absolutely huge, but the idea is to take a look at that ratio. And if you see something funny in there, there probably is something funny in there. And it's not funny. It's costing you money. And so that's lean strategies in revenue cycle management. So do we have any questions?
Not that I see so far. Thank you, Dr. Wagner, for your insightful presentation. Hopefully everyone else was able to hear the entire portion, and I'm glad to be back with you now. If you do have any questions, it is open for that now. Please use the Q&A panel on the right to type in your question. We also have an Ask a Question option, which is a drop-down box near the text box, and we could unmute your line and you could ask the question directly. Dr. Wagner, if you don't mind holding for a little bit, let's just see if any questions come through the chat.
No, I'm right here. I can't see the chat, so you'll have to ask me the question.
I will read them out if I see any. I haven't seen any come through yet, so maybe you just did such a great job. You've answered everybody's questions, or if you have any later, you are able to ask them afterwards as well. Well, is there anything else you wanted to cover before wrapping up, Dr. Wagner?
No, I think this covered lean strategies and revenue cycle management.
Excellent. Well, thank you again for that, and I look forward to hosting you all again soon. Thank you for tuning in today, and have a wonderful day ahead.
Thank you.
All right, I think the session went good today, pretty much.
You said it went well?
Mm-hmm.
Okay, good.
So we did have good audio.
No do-overs, huh? We'll need a lean strategy for webinars. That'll be the next webinar. So what's next?
So we can I can give you a call and we can discuss more on that.
Okay,
right?
very good. All right, so I'm going to go ahead and hang up now.
All right, so you can just click on the green button again so that you're off air, so that the session gets recorded.
Okay, tried that and it's not working. I have to end the call.
All right, just a second. Let me just get there. So Kaylin, are you still there?
No, Kaylin left the meeting.
All right. I think it was a bit late for her.
Yeah, I don't know what time zone she's in.
I think she's in the Eastern time zone.
Oh.